Good morning. I've got the TOG summary for the January 2023 TOG. This is much awaited. I hope you'll find this really useful. Don't forget to give this video a thumbs up and subscribe to my channel if you haven't already. So the first article we're going to talk about is premenstrual disorders, including premenstrual syndrome and premenstrual dysphoric disorder. So 20 to 40% of patients have severe premenstrual syndrome. The good news is only 3 to 8% of these patients tend to have the extreme of the symptoms. So what symptoms are we talking about? So symptoms include effect on psychologically, physically. So psychological symptoms like depression, anxiety, mood swings, irritability, loss of confidence. Physical symptoms like breast tenderness and abdominal bloating. So this is a little diagram that shows you what happens to the progesterone in the body and how it's metabolized and then formed into something that's more useful. So progesterone, with the help of 5-alpha reductase, is broken down into 5-alpha dihydroprogesterone. This is then further metabolized by 3-alpha hydroxysteroid dehydrogenase to allopregnanolone. So this is quite a useful thing to know, especially can be an easy SBA in the exam, and it's something you don't want to miss your marks on. So we're now talking about mild to moderate PMS and severe PMS, including the PM dysphoric disorder. So the prevalence of mild to moderate is 50 to 80%, severe is 3 to 8%. Severity of symptoms, so in the mild to moderate, the symptoms are also classified as mild to moderate. With the severe, you have severe symptoms. Presenting symptoms for mild to moderate may be physical or emotional or both. With severe PMS, the symptoms tend to be mostly predominantly emotional. There's no diagnostic criteria for mild to moderate. However, for severe PMS, there is the DSM-5 criteria. Effective symptoms for the mild to moderate may or may not be present. With severe PMS, they're always present. Who can manage? So usually managed in primary care, the mild to moderate PMS, where severe PMS mainly needs a referral to secondary care, multidisciplinary care. Treatment can be managed with lifestyle modifications if mild. With severe, mostly need pharmacological treatment, may also need surgery. So, diagnostic approach to premenstrual dysphoric disorder, prospective recording of symptoms over 2 cycles, documenting severity of symptoms, cyclical relation to the menses, and symptom-free period before next ovulation. Symptoms severe enough to affect quality of life, rule out whether other medical or menstrual disorders with similar presentation, use DSM-5 criteria to diagnose PMDD, which is premenstrual dysphoric disorder. Symptom diary to be completed before start of treatment to avoid masking of symptoms. Okay, sorry about this. It's a very busy slide, but basically talks about first table here. So I've got 3 tables here, but the first table talks about International Society of Premenstrual Disorder classification of premenstrual disorder. So you've got classification into its core PMD and then variants of PMD, described as such. So for the core PMD, you have symptoms occur in ovulatory cycles. Symptoms are not specified. They may be somatic and or psychological. The number of symptoms is not specified. Symptoms are absent after menstruation and before ovulation. They must recur in the luteal phase. They must be prospectively rated, so 2 cycles minimum. Symptoms must cause significant distress or impairment, for example, to work, school, social activities, hobbies, interpersonal relationships. Variants of PMD, so you've got premenstrual exacerbation, so you've got symptoms of an underlying psychological or somatic disorder. PMD due to non-ovulatory ovarian activity. Symptoms result from ovarian activity other than those of ovulation. Progesterone-induced PMD symptoms result from uh, exogenous progestogen administration. PMD with absent menstruation symptoms arise from continued ovarian activity even though menstruation has been suppressed. So this is the DSM-5 diagnostic criteria for PMDDD. So you've got A, B, C, D, E, F, G, definitive temporal relation to menstrual cycle. Symptoms must be present in the last week of menstrual cycle before the onset of menses, start to improve within few days of the start of menses, and become minimum or absent in the week post menses. B and C, minimum 5 out of 11 symptoms with at least one core symptoms. Should be present for most of the cycle over the past 12 months. D is symptoms to interfere markedly with usual activities, for example, work, school, social relationships. E, symptoms are not a mere exacerbation of an underlying condition, for example, depression or anxiety. F, not attributable to the physiological effects of substance or other medical condition, for example, drug abuse, medication, other treatment, thyroid disorders. G, PMDD should be confirmed by prospective daily symptoms for 2 consecutive cycles. Symptoms of PMDD for DSM-5 criteria: core symptoms, marked affective lability, example, mood swings, feeling suddenly sad or tearful, or increased sensitivity to rejection, marked irritability of anger or increased interpersonal conflicts, marked depressed mood, feelings of hopelessness or self-deprecating thoughts, marked anxiety, tension, and feelings of being keyed up on or edge. Additional symptoms: decreased interest in usual activities, difficulty in concentrating, lack of energy, easily fatigued, marked changes in appetite, food cravings, feeling overwhelmed or out of control, changes in sleep, physical discomfort such as breast tenderness, joint or muscle pains, headaches, bloating, and weight gain. Selective serotonin reuptake inhibitors, so SSRIs, and selective norepinephrine reuptake inhibitors, SNRIs. So regimes can be continuous or luteal phase, so day 15 to 18. So you know, different patients may need different sort of regimes. So you either give it continuous or you give it only during the luteal phase, which is the day 15 to day 28 of the cycle. Doses of fluoxetine is 20 milligrams a day. Sertraline would be 50 to 100 milligrams a day. Citalopram would be 20 milligrams a day. Escitalopram would be 20 milligrams a day, and paroxetine would be 20 milligrams a day as well. Side effects include nausea, insomnia, somnolence, fatigue, reduced libido. How to discontinue treatment? So if the patient's on the luteal phase regime, then discontinue at any time. If the patient's on continuous regime, then taper the dose over a period of time to avoid withdrawal symptoms. So evidence-based treatment approach. So first line is reduced effect of hormone fluctuation on neurotransmitters. So lifestyle modifications, complex carbohydrate diet. During the luteal phase, aerobic exercise, yoga, meditation, exposure to sunlight, stop smoking and alcohol. CBT can help. Neuromodulators can help, like SSRIs and SNRIs that we've talked about in the last slide. Combined oral contraceptive pill can help because it can reduce fluctuations in the hormone levels. For women not planning pregnancy, short hormone-free interval regime of drosperinenon 3 milligrams and ethinyl estradiol 20 micrograms can help. Combined oral contraceptive pills in continuous or tricycle pattern can help. Levonorgestrel 90 micrograms and ethinyl estradiol 20 micrograms continuously for 3 to 4 months without a break. Second line would be the combined a combination therapy with SSRIs and combined oral contraceptive pills. Estrogen therapy with patches can help. Third line is reduced fluctuations in hormone levels with GnRH analogs plus or minus add back hormone replacement therapy. Fourth line is reduced fluctuation in hormone with total hysterectomy plus bilateral salpingophrectomy plus or minus HRT. Novel therapies are currently under research is things like 5-alpha reductase inhibitor. So we see why this is important because, you know, as I discussed earlier, it's that conversion of, you know, using that 5-alpha reductase that then results in the progesterone being broken down to something that is more that the body can use. So by giving an inhibitor, you're stopping that. There's also other treatments that hopefully you don't need to know too much about. Right, we move on to the next talk, which is human papillomavirus independent cervical cancer and its precursor lesions. Cervical cancer, so HPV independent squamous cell carcinoma of the cervix is rare. It's between 5 and 7%. Cervical cancer is the fourth most frequently diagnosed cancer and the fourth leading cause of cancer mortality in women. 5 to 11% of cervical cancers worldwide are HPV negative. So you've got this little flowchart, cervical tumors and precursors. So you've got squamous and glandular. Squamous can be HPV associated or they can be HPV independent. So the HPV independent, they are squamous cell carcinomas. If you have glandular, so you can have HPV associated as well, and you can have HPV independent. HPV independent tend to be adenocarcinoma, for example, gastric, clear cell, mesonephric, not otherwise specified carcinoma. HPV independent can also be the atypical types, and also can be the GIS types as well. Again, these hopefully you don't need to know too much about these, but it's useful to know the division of you know of these different cancers. So LEGH stands for lobular endocervical glandular hyperplasia. So and that's under the definition of the glandular carcinomas. Causes of human papillomavirus negative tumors, so HPV independent cervical cancer, so false negative HPV test results, loss of HPV DNA fragments, low viral load, etiological agent is non-high risk HPV, sampling error, technical factors associated with various HPV tests, histological misclassification, so extension of endometrial cancer to the cervix, distance metastases from other HPV negative primary tumors. So cytological differences between HPV-associated adenocarcinoma and HPV-independent gastric adenocarcinoma. So in HPV-associated adenocarcinoma, you find crowded hyperchromatic groups, cytoplasmic and nuclear feathering, enlarged nuclei with coarsely granular hyperchromatic chromatin, with obvious apoptotic mitotic figures, macronuclei and tumor diathesis seen. In HPV independent, you have monolayered and honeycomb sheets, vacuolar and foamy cytoplasm with intracytoplasmic golden yellow mucin, vesicular nuclei with distinct nucleoli, rare apoptotic and mitotic figures, intracytoplasmic neutrophil entrapment. Right, this moves us on to the third TOG for this edition, so valvular heart disease in pregnancy. So regurgitant lesions are better tolerated than stenotic lesions. Right-sided lesions are better tolerated than left-sided lesions. Causes of stenotic valve lesion in childbearing age, predominant causes rheumatic heart disease for mitral lesions, and congenital bicuspid valves with superimposed calcification for the aortic lesions. So ECG, echo, and exercise tolerance test should be performed in all women as a baseline in pre-pregnancy assessment of cardiac function. Adverse consequences for the fetus occur in as many as 30% of cases of maternal cardiac disease and correlate with maternal disease severity. Serial ultrasound scans 4-weekly basis from 24 weeks are recommended. Stenotic valvular disease and symptomatic regurgitant disease increase risk of fetal growth restriction by up to 30%. Preterm birth and fetal growth restriction happens in moderate or severe aortic stenosis in 20 to 25%. So New York Heart Association functional classification. So class 1, 2, 3, and 4. Patient symptoms. So class 1 is no limitations on physical activity. Ordinary physical activity does not cause undue fatigue, palpitations, or dyspnea. Classification 2 is slight limitation of physical activity, comfortable at rest. Ordinary physical activity results in fatigue, palpitations, or dyspnea. Classification 3 is marked limitation of physical activity, comfortable at rest, less than ordinary activity causes fatigue, palpitations, or dyspnea. Number 4 is unable to carry on any physical activity without discomfort, symptoms of heart failure at rest. If any physical activity is undertaken, discomfort increases. Severity of mitral valve stenosis determined by the valve area. So mild, moderate, severe. So mild is over 1.5 centimeters square, moderate is 1 to 1.5, and severe is less than 1. So modified World Health Organization classification of maternal cardiovascular risk. So class 1, risk of pregnancy, no detectable increased risk of maternal mortality, and no or mild increase in morbidity. So examples of conditions are uncomplicated or mild pulmonary stenosis, patent ductus arteriosus, mitral valve prolapse, successfully repaired simple lesions. So classification 2 is small or increased risk of maternal mortality or moderate increase in morbidity. Unoperated atrial or ventricular septal defect, repaired tetralogy of Fallot, and most of arrhythmias. Classification 3, significantly increased risk of maternal mortality or severe morbidity, so mechanical valve or systemic right ventricular Fontaine circulation. So expert counseling is required if pregnancy is decided upon. Intensive specialist cardiac and obstetric monitoring is required throughout pregnancy, childbirth, and the puerperium. So it also includes conditions like Fontaine circulation, cyanotic heart disease, other complex congenital heart disease, aortic dilatation. Okay, so the number 4 is extremely high risk of maternal mortality or severe morbidity. So if pregnancy occurs, termination should be discussed. If pregnancy continues, care for as class 3. So pulmonary arterial hypertension, severe systemic ventricular dysfunction, previous peripartum cardiomyopathy with any residual impairment of the left ventricular function, severe mitral stenosis, severe symptomatic aortic stenosis, Marfan syndrome with aortic dilatation and aortic dilatation greater than 50 millimeters in aortic disease associated with bicuspid aortic valve, and native severe coarctation. Summary of anesthetic aims in valvular heart disease: so maintenance of a heart rate adequate for the lesion, avoidance of hypotension and breakthrough pain, strict fluid management, pulmonary edema occurs readily and hemorrhages poorly tolerated, adequate cessation of anticoagulation, facilitating placement of regional anesthesia. Well, I hope that was useful for you, and it was. If it was, please give this video a thumbs up and also subscribe to my channel if you haven't already. If this was useful, please leave a comment, and good luck for your revision.